Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Primary Tumor Response to Preoperative Chemoradiation with or without oxaliplatin in Locally Advanced Rectal Cancer, Pathologic Results of the STAR-01 Randomized Phase 3 Trial by Carlo Eschelli et al. My name is Rebecca Mixad, and I am an attending physician at Beth Israel Deaconess Medical Center and an assistant professor at Harvard Medical School in Boston, Massachusetts. My oncologic specialty is gastrointestinal malignancies. Recording the podcast title, Pathologic Complete Response and Toxicity Results from the STAR-01 trial evaluating the addition of oxaliplatin to neoadjuvant chemoradiation for locally advanced rectal cancer. The cornerstone of curative treatment for rectal cancer is surgical resection. However, unlike colon cancer, rectal cancer has a high rate of local recurrence. In addition, mortality for locally advanced rectal tumors is 30% or greater. The explanation for this mortality difference compared to similar stage colon cancers may be due to the impact of the close confines of the pelvis on surgical margins, the vascularity of the perineum, the lymphatic drainage pattern, and inherent tumor biology. Therefore, efforts to improve outcomes for locally advanced rectal cancer have focused on optimizing radiation and chemotherapy treatment. The German cancer study by Sauer et al., published in 2004, established fluorouracil-based neoadjuvant chemoradiation as standard treatment for T3 tumors that invade through the bowel wall into pericolorectal tissue and T4 tumors that involve other organs. This neoadjuvant approach can sometimes sterilize the rectal tumor prior to surgery, resulting in a complete pathologic response, and provides a significant reduction in local relapse rate. In addition, neoadjuvant therapy can offer an important quality of life benefit when tumors are, quote, downstaged, end quote, enough to allow sphincter-sparing surgery. Despite these important gains made with neoadjuvant chemoradiation, there has been no decrease in the rate of distant metastasis, which remains about 30%. In addition, only 10 to 15% of patients achieve a complete pathological response with neoadjuvant therapy. Therefore, additional gains in survival require improvements in both systemic and local control. Several large studies, including the STAR-01 report that is the subject of this podcast, were developed based on the hypothesis that the addition of oxaliplatin to fluorouracil-based neoadjuvant chemoradiation might improve overall survival for rectal cancer through improved response of the primary tumor and enhanced control of micrometastasis. This hypothesis is based on evidence that oxaliplatin can function as a radiosensitizer, that the combination of oxaliplatin and fluorouracil is effective in colon cancer treatment, and that oxaliplatin-containing neoadjuvant therapy yields a 25 to 30% complete pathologic response rate in Phase 1 and 2 rectal cancer studies. Although the primary outcome of this Phase 3 multi-center randomized study is overall survival, the current manuscript reports the protocol-planned analysis of the pathologic response to neoadjuvant fluorouracil-based chemoradiation with and without oxaliplatin. Eligible patients had biopsy-proven, clinically resectable, locally advanced rectal adenocarcinoma defined as either T3 or T4 tumor, or regional lymph nodes at least 5 millimeters in size. A good performance status and standard normal organ function were required. Patients in 41 centers in Italy were randomized centrally to receive radiotherapy and concurrent continuous infusion fluorouracil with or without oxaliplatin given weekly for 6 weeks. Surgery was scheduled 6 to 8 weeks after completion of chemoradiation, and all patients who underwent curative resection were planned for adjuvant fluorouracil-based chemotherapy regardless of the pathologic findings. The STAR-01 report that is the subject of this podcast focuses on a protocol-planned analysis of the pathologic findings of the resected tumor specimen. Tumors were processed and evaluated according to standard protocols. The study had an 80% power to detect an 8% absolute difference in pathologic complete response between the two arms using an intent-to-treat analysis. A total of 747 patients were enrolled in the STAR-01 trial, and the two treatment arms were balanced for clinical and pathologic characteristics. Prior to therapy, 15% of patients had clinical T4 tumors and 65% of patients had clinical lymph node involvement. Compliance and toxicity were reported for actual treatment received. 352 subjects received oxaliplatin in addition to fluorouracil-based chemoradiation, and 379 did not. One of the important findings of the study was the extent to which oxaliplatin interfered with the ability of patients to receive all of the planned radiation and chemotherapy. With a target goal of 80% of the planned chemotherapy cumulative dose, only 75% of subjects on the oxaliplatin arm met the oxaliplatin dose goal, and only 80% achieved the fluorouracil dose goal. In contrast, 90% of subjects on the fluorouracil arm attained the cumulative chemotherapy dose goal. This difference was statistically significant. A more worrisome finding is that subjects on the oxaliplatin arm were significantly less likely to receive the full planned cumulative radiation dose. Only 84% of subjects on the oxaliplatin arm completed radiation, compared to 92% of subjects on the fluorouracil alone arm. Toxicity was the primary cause for decreased chemotherapy and radiation dosing and was significantly greater for subjects on the oxaliplatin arm. Grade 3 and 4 adverse events occurred in 24% of subjects on the oxaliplatin arm, compared to 8% of subjects on the fluorouracil alone arm. Diarrhea, radiation dermatitis, and asthenia were all significantly greater in patients receiving oxaliplatin. Of these, diarrhea was the most common and affected 15% of subjects. Nonetheless, on both arms, more than 95% of subjects underwent surgery, and surgical complications were low. The median interval between the end of chemoradiation and surgery was less than 8 weeks for both arms, although the range for the oxaliplatin arm was twice as large. Pathologic examination was performed on 705 total mesorectal excision specimens, which accounts for 89% of enrolled subjects. Unfortunately, there was no difference in the pathologic complete response rate between the two treatment arms, 16% for both groups. The 16% complete pathologic response rate in the control arm is somewhat higher than historical experience, possibly due to optimization of radiation dosing. The 16% rate on the experimental arm is lower than the expected based on prior results from single-arm trials. The presence of positive regional lymph nodes was similar in both arms, 26% and 29% for the fluorouracil and oxaliplatin arms, respectively. For patients with residual tumor, there was little difference between the arms for the percent of patients in each T subcategory, the median diameter of the resected tumor, and the degree of tumor regression. Despite the lack of difference in the pathologic findings for the primary tumor, there were significantly more patients in the fluorouracil-only arm with intra-abdominal distant metastasis, 2.9% versus 0.5%. In summary, the pathologic findings in the STAR-01 randomized phase 3 trial highlight the need to think differently about how to make progress in advanced rectal cancer. Despite promising preliminary evidence supporting the addition of oxaliplatin to neoadjuvant fluorouracil-based chemoradiation, this trial suggests that the primary effect of oxaliplatin when used in the neoadjuvant locally advanced rectal cancer setting is increased toxicity. This conclusion is consistent with the results of the ACCORD trial previously reported by Gerard et al. Nonetheless, it is important to point out that the overall survival data from the STAR-01 trial are still pending, and that oxaliplatin may still have some systemic benefit as demonstrated by the decreased intra-abdominal metastasis at the time of surgery. Longer follow-up is necessary to address this point. However, unless the pending report of the National Surgical Adjuvant Breast and Bowel Project, NSABP, R04 trial offers more positive results, the message for locally advanced rectal cancers seems to be that the paradigm of adding more drugs to neoadjuvant therapy does not always work, and that novel approaches to individualized therapy are needed in order to improve outcomes. The results of the STAR-01 trial also have broader implications for the manner in which oncology research is conducted. 3 large randomized trials were initiated in the mid-2000s to essentially examine the same question: does oxaliplatin add benefit to neoadjuvant fluorouracil-based chemoradiation? Nearly 3,000 subjects have contributed to the 2 trials reported to date and to the NSABP R04 trial. If pathologic complete response is the key factor in influencing outcomes for locally advanced rectal cancer, there must be a better and more efficient way to move the field forward than engaging a large number of patients and investigators to repeatedly answer the same question. Based on the randomized trial data reported to date, the standard of care for locally advanced rectal cancer remains neoadjuvant fluorouracil-based chemoradiation without oxaliplatin. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.